Thanks everyone for joining us. We appreciate your being here. My name is Rajiv Ramchand, along with my colleague Carrie Farmer. We co-direct the Rand Epstein Family Veterans Policy Research Institute. We're really excited for today's presentation, which is really looking at supporting veterans' needs at state and local levels. We often hear about federal policy and we talk about federal policy, but as many as we are all aware, veterans in our great country live in states, and there are state policies and there are policies at the local level that affect veteran outcomes and the outcomes that we care most about. And so we really wanted today's discussion to really focus on that diversity across states and show examples and have a discussion about state policies at local levels. Before I start off, just some housekeeping notes. We do have the chat feature and we have the Q&A feature. We'll monitor both. The chat feature is really helpful if people, especially state or local representatives, want to put in some links to what you offer within your state or any websites. That would be great, or any resources for us. The Q&A is what we'll be using for our moderated discussion to either type answers to questions live, or to respond to questions in our moderated panel discussion. As we kick things off, I'm just going to kick things off for a 10-minute, 15-minute presentation on some of our findings of veterans' needs at the state and local levels, and then we'll turn it over to the panel discussion that Dr. Farmer will moderate. Next slide, please. For those of you who are not familiar, the Rand Epstein Family Veterans Policy Research Institute, located within Rand, has at its mission to conduct research that improves the lives who served and those who support them. We host webinars every other month. Typically, they're on Thursdays at 1 p.m. Pacific, at 4 p.m. Eastern. Because of the federal holiday tomorrow, we are having it one day early today on Wednesday. So thank you for joining us. And if any of you noticed why, that's the reason. So next slide. As I said before, I'm Rajiv Ramchand, and I'm just going to be walking you through some of our slides and some of our results. So thank you. I won't introduce myself any more than that. You can Google me. So as I mentioned before, there are 18 million veterans who live in the United States. This is a number we hear a lot, but they're not evenly spread out across the country, and they live in various different states and communities. Next slide. One way you can look at that is the number of veterans who live at each state. And this is our most recent data. So what I think is really interesting is that 3 states account for a quarter of where all veterans in the United States live. That's California, that has just over 1 million, Texas, that has close to 1.5 million, and Florida, that has 1.3 million. In contrast, we have states where there's the fewest number of veterans. So less than 100,000 in Alaska, in Montana. So we have just really various or a varying degree of the number of veterans across the United States and where they live. Next slide. But as you'll notice, a lot of the places where veterans live that are most populated with veterans, these are the most populated states in general, like Texas and California. And you'll see that in those states, less than 5% of the population is actually a veteran. And this stands in contrast to some of those states where there's much fewer by number of veterans, but they actually account for a greater proportion of the state's population, like Montana and Alaska, where we see over 7% of those living in the states are veterans. So this is something that sometimes we have to balance, which is kind of the density of the veteran population within states versus kind of the sheer numbers, and thinking about that as we kind of allocate resources and make sense of these state policies. Next slide. So the first, since the Institute was funded and established, the first thing that we looked at, and this was right in the middle of COVID, and everyone was worried about recessions. And so we really started to look at that by thinking about how might veterans be impacted if there were a recession during COVID. Next slide. This was work that was led by Dan Schwam and Jim Marone. And what we were able to do in that study was look at the industries in which veterans were employed. And the two of the top industries in which veterans were employed were in manufacturing and retail. What was concerning is that those were the industries that were expected to experience negative job growth, so a reduction in jobs. And if that wasn't kind of fact enough, these industries are not uniformly distributed across the United States. So we see heavy concentrations, for example, of manufacturing in the Pacific Northwest and the upper and the kind of the Great Lakes region. So this was the first indication that, not all things are equal. And as we're kind of projecting and thinking about how veterans might fare during a potential recession, we have to think of these local geographies because they're going to become really important. Next slide. We often hear that over 6,000 veterans die by suicide each year, but we also, and we've done a lot of research on this, but we also have noticed that that these are also not equally distributed. So next slide. So there's two ways to think about suicide. So the rate is often a number per 100,000 veterans. And so you'll see, and then the number, the N, as we said before. And so what you'll see, and I misspoke, 25%, these three states, Florida, Texas, I said before, 25% of the veteran population are in California, Texas, and Florida. That was a misstatement. 25% of veteran suicides are located in California, Texas, and Florida. But you'll see here that the rates is another way to look at it. So we have to focus our suicide prevention efforts for veterans in these three states if we're going to make a dent, because they comprise a quarter of suicide deaths. But if you look on the next slide, I'm going to show you the rates of suicide, and where the rates are the highest are actually in the states of Montana, Nevada, and Utah there. So what you'll see that the rates per 100,000 are close to 87 or 52, over 50 per 100,000, relative to those rates of 30 per 100,000 or less in some other states. So this also presents a conundrum that's very common in suicide research, where we have to target those areas where there's a lot of veterans who are dying by suicide, but we can't do it at the expense of these states in which they account for fewer number of suicides, but risk of suicide in these states is much larger in places like Nevada, Montana, and Utah. Next slide. Work that was led by Andrew Morrell and Terry Schell looked at the method of suicide death. And what they found was that this increase in suicide risk among the veteran population is almost exclusively attributed to differences in firearm suicide deaths. So you'll see that 1.04 on the right of non-firearm suicides, that's kind of a measure of the difference if you were to divide the civilian and veteran suicide rate. And it's close to 1, so meaning they're almost comparable. But it's 40% greater, or 1.4 times the risk among firearm suicides. And firearm suicides are also not equally distributed across the country. What we know are the states in which there's high prevalence of firearm ownership is where there's a high rate of firearm suicides. The two are very closely related, and we're trying to unpack, the reasons why that might be. But state policies that affect firearms, everything from the way firearms are stored to minimum age requirements for purchasing, those states that have less restrictive policies are also the states in which there's a higher prevalence of firearms, as might be expected. So again, risk really varies across states depending on how many guns are available, what proportion of households own firearms, as well as the policies that affect ownership. Next slide. Our next way that we looked at state variation in veteran outcomes was looking at food insecurity. And one of the things that we found, and that you'll see this as trends over time, in the percentage of veterans who are food insecure who access SNAP. And what you see here is that fewer veterans on the blue line are receiving SNAP than non-veterans among those who are food insecure. So it's around 30% of veterans who are food insecure access SNAP benefits. Next slide. But states vary in the ways in which they administer SNAP benefits. So we don't call out specific states, but we found in our analysis that those that implement broad-based categorical eligibility for SNAP, those who have a combined application for SNAP and Social Security income, and those that operate call centers in which people can apply for SNAP benefits tend to have greater participation in the SNAP program among those who are food insecure, including among veterans who are food insecure. So we see that the way states are administering SNAP really affects veteran outcomes and uptake of SNAP benefits among those who are food insecure. Next slide. Our colleagues, Megan Schuler, Michael Dunbar, Elizabeth Ross, and Josh Breslow examined state policies for LGBTQ plus individuals, not veterans per se, but then they looked at how these state policies might impact the outcomes for LGBTQ veterans. Next slide. So what we found is better health outcomes in large part in those states that had more accepting state policies. So what you'll see is that veterans in states with more accepting policies were more likely to have health insurance coverage. They were less likely to report poor mental health, and they were also less likely to smoke cigarettes. So we examined, controlling for a whole bunch of features, but we did see our veterans' outcomes were better in those states with these more accepting policies. Next slide. We also have looked and done deep dives, as we call them, into certain states. And our most recent was work that was led by Jeannie Ringel, and that was for New York State, and it was funded by the New York Health Foundation. In that study, what we were able to conduct a survey with a random sample of over 1,000 veterans who were discharged or separated from the military between 2018 and 2023. So a recent cohort of veterans. I'm going to present some of the input that we found about this group to shape New York State policy. Next slide. So the first is that we see many veterans in New York are not getting care they need. So they were asked, have you needed care but haven't received it? And we asked the reason why. And so 15% of veterans needed physical health care but weren't receiving it. And the barriers will include difficulty in access care, lack of supportive services like childcare should they go to a healthcare provider, and the high cost of care. 21% of this recent cohort of veterans felt that they needed mental health care but didn't receive it. These veterans also reported access difficulties, but two different issues emerged as kind of some of their top reasons. First is that they perceived the available mental health treatments to be ineffective. And then there was also this stigma that they would be treated differently by their peers or by their colleagues should they actually access mental health care and it be known. Next slide. We also asked veterans where they wanted to seek care. 46% preferred to seek it from a community provider, 31% from a VA facility, and the remainder from other options that were asked. And I think this is really important as New York State kind of thinks about what resources will be in place for veterans, especially as things like the VA community care program expand. Next slide. We're continuing to do work on state policies. One of the issues that we know varies from state to state is policies on psychedelic use. We've seen states even offer significant amounts of grant funding to conduct research on the use of psychedelics for veteran mental health. And so that's work that's being done by Michelle Priest and Bo Kilmer, who are looking into that. We also have our study, kind of a similar deep dive that we did for New York State that's looking at veterans' needs in Massachusetts that'll be coming out later this year. Next slide. I'm just going to conclude, and this is my last kind of little bit of research. We've been talking a lot about states and state policy, but I want to speak briefly about what's happening at the micro level, so within counties across states. And one of the ways that we can look at that is how much veterans are spending on housing. Next slide. So we measure how much people spend on housing and we apply thresholds. If individuals are spending 30% or more of their income, we consider it moderate housing cost burden, and 50% or more of their income on housing costs to be severe housing cost burden. Next slide. So nationally, if you look on the left-hand side, for the past at least 15 years, fewer veterans have been considered housing cost burdened. So this is those who are moderately or severe housing cost burden. And you see most recently in 2021, 22% of veteran households were housing cost burden relative to 31% of non-veteran households. And this is work led by Megan Andrew, Vanessa Parks, and Dan Schwam. And they call this the veteran advantage in housing cost burden. Next slide. And you'll see that when we look at smaller regions of the country or different regions, we can see that this persists. So in Alabama, in these counties in Alabama that we combined, you see that 8.7% of veterans were housing cost burden relative to nearly 25% of non-veteran housing costs. So it persists in some places. Next slide. Oh, next slide. Sorry, we just have another example. But that's not necessarily the case everywhere. So in Boston, we see more veterans are housing cost burden. 50% of veteran households in Boston are housing cost burden relative to 47% of non-veteran households. Next slide. And the same is true in Los Angeles, where nearly 75% of veteran households are burdened relative to 58% of non-veteran households. So again, if we take these national estimates and not look at the more refined geographic regions in which veterans live, we just assume that always veterans have lower housing cost burden than non-veterans. And we see that looking at these micro levels, that these trends don't necessarily persist. And it calls focused attention to some of these regions. Next slide. I think the theme from all this research is that sometimes these problems are national problems, but they have local origins and require local solutions. And now I'm going to introduce my colleague, Carrie Farmer, who's going to lead a moderated discussion about these findings and your own questions. So thanks.
Great. Thank you, Rajiv. That was a really great overview of a lot of research that we've been conducting, and I think raises a lot of hopefully I know we'll have a great discussion here. I want to introduce our panelists who are joining us today, who are representing some different perspectives on the geography and the places where veterans live. So first we have Brandy Jankaitis, who is the director of the Virginia Veteran and Family Support Program at the Virginia Department of Veteran Services. So she's representing the state, and in Virginia's case, the Commonwealth perspective. We have Tim Shepard, who's the president of the National Association of State Directors of Veterans Affairs, and he's also the executive director of Wyoming's Veterans Commission. And then finally, we have Andrew Tangen, who's the first vice president for the National Association of County Veteran Service Officers. And he serves as a superintendent of the Veterans Assistance Commission of Lake County, Illinois. So welcome to all of our panelists, and thank you so much for joining us. Great. So I'm going to start off with a question for Brandy, specific to Virginia. I think when we think about the challenges for the country, and then as Rajiv showed in all of this data, that the challenges might be a little bit different in different places within the country. And so I'm curious, what are some unique approaches or programs that Virginia has to support veterans, and how does that sort of local context or like at the Commonwealth level play into how you think about what services are needed for veterans in Virginia?
Absolutely. Thanks, Carrie. So, and thanks to the RAND team for inviting Virginia to be a part of the discussion. And a shout out to any of our Virginia stakeholders on the line, as well as any of our neighboring states that serve Virginia's veterans and families. So the Virginia Department of Veteran Services desires to have services across the lifespan for our veterans and family members. So there'll be different ways that I'll highlight that throughout our panel. But to kick off, I wanted to dig in on key groups amongst the veteran population that might need specialized outreach and support. And so one of the things I wanted to highlight is that it's important at that state level to be a gap fill and to keep our eligibility where possible for agency services as broad as possible, because there's going to be a subset of veterans that federal VA care and support is not going to be, they're not going to be eligible, or it's not going to be accessible for other reasons, which could just boil down to timing of services availability as far as when they're working, or transit time, lack of transportation. So within our agency, we're fortunate to have a program called Virginia Veteran and Family Support that provides care coordination, veteran peer recovery services, and specialized outreach and support to justice involved, which includes across the criminal justice spectrum, as well as specialized outreach for those experiencing housing barriers and homelessness. So I'm pretty proud of, I run it, so I'm a little biased, but I'm pretty proud of how Virginia has went above and directly employs those supports. Sometimes what you'll see in other states, as Tim and others will highlight, is that those supports are available for those groups that may face more barriers to access to care, but perhaps they're doing it through partnerships. So it can be done in a lot of ways, but Virginia directly employs those resource-oriented and recovery-oriented staff. And then the second one I want to talk about is 3 years ago, Virginia was fortunate to get a state funding appropriation for suicide prevention and opioid addiction services, a $5 million appropriation. That was the largest single state funding investment in veteran suicide prevention ever. And what we did with that at the state level is we created a grant program called the SOS program, Suicide Prevention and Opioid Addiction Services. So we were able to take state general funds and put them into community organizations around the state that could address behavioral health services needs across the spectrum. So that includes things like prevention, training and awareness, intervention, what you think of more as like clinical services and treatment at the community level, and then postvention, or how to help communities cope with a loss or ongoing recovery needs. So Carrie, that's just a few things that we're doing kind of above and beyond.
That's great. Thanks so much, Brandy. And then Tim, you have a different perspective. Well, you simultaneously have two perspectives for Wyoming, but then in your role for NASDVA, sort of looking across states. And so what do you hear from state directors of Veterans Affairs across the country in terms of the differences in veterans' needs and the resources available at the state level in different places?
Thank you, Carrie. I appreciate the opportunity to be on today. And I too will do a shout out, but I'll do it to the 56, which are the 50 states, the 5 territories, and our great District of Columbia that make up NASDVA, and support the 18.2 or 3, whichever percentage you want to take, that make up the millions of veterans out there who desperately, in some cases, and not so desperately in other cases, need support. But it's you had a map up that was pretty granular, and what it made me think was, that's what the service world is like. It's just that different. And you can go to a state and you can have rural conditions and you can have urban conditions, and you can have everything in between. So and there are very few similarities between the 56. What we do in Wyoming is not what Brandy's doing in Virginia necessarily to take care of their veterans, but yet they're taking care of their veterans and we're taking care of our veterans, and the other states and the territories are doing the same thing. It's just, it's so different. And I equate veterans to snowflakes. No two are the same. So therefore, you really have to be careful when you say, well, I think we have found the fix. You may have found the fix for that, but will it be the fix for this? And when we apply it, we may have to apply it just a little bit differently, and yeah, we'll get the fix. But so long story short, I'll go back to what I said at the beginning, and that is, it's very different across the 56.
Yeah, and I think then turning to Andrew, that's even more true. You know, veterans, they live in the country and they live in a particular state, but then they ultimately live in a community. Your organization, NAC VSO, is responsible for county veteran service officers. And so can you say a little bit about sort of what the role of veteran service officers are in different places in the country? Because they have different roles, and obviously states and counties are using this function in different ways.
Absolutely, and thanks for Carrie and the RAND team for having me on. And I'm gonna do the exact same thing my two other colleagues did and give a little shout out to the 42, and that's the 37 states and the 5 Native American tribes that are members of NACVSO. We're actually working to add more of those tribes, so there's 596 federally recognized tribes, and we're working to have their service officers become members so that we can help them with adjudicating claims. As Rand probably knows, Native Americans are the #1 lowest served veterans population out of any other demographic, and that's something that NACVSO has taken on to try and address. And even so, and I know our name is the National Association of County Veteran Service Officers, but really when you peel back the onion a little bit, we're actually more government veteran service officers instead of county specific, because not every state has counties. Like Massachusetts, for example, they do not have county governments, so they have municipal veteran service officers. And I mentioned the tribal veteran service officers earlier. So we have county, we also have state service officers that are members, we have municipal, and then we have tribal service officers as well. And so within the NACVSO umbrella, our job is to work with each and every individual GVSO to help them have the best training possible to be able to advocate for their veterans, the best practices possible to be able to understand where different areas, because throughout the entire United States, like everybody has said, there's rural, there's urban, there's suburban areas that are all varying degrees of economics and economies to be able to provide different levels of responses to veterans. So as far as NACVSO is concerned, just like with NASDVA, not one specific program or one specific idea is going to be the solution to each individual problem. The Native American tribes, for example, they have a whole different burden when it comes to helping their veterans than the rural veteran service officer, which is completely different from an urban service officer. You know, what works in Los Angeles County, which is the largest county veteran population and the largest CVSO office, is not going to work for the Apache Nation in Arizona. So we work to try and bring together best practices and training available to be able to describe things that have worked, and then give individual service officers the plans and the ideas to go back and try to implement their version of those plans.
That's great. And you actually anticipated a follow-up question I was going to ask, and I'll ask it of Tim and Brandy as well. Sort of how, given that there are, these differences across the country, both, in states and in more local levels of geography, but there are lots of sort of mini experiments going on in different places. And what are ways that your organizations try to help spread those best practices and allow there to be learning from state to state or county to county or whatever level of geography makes sense?
Okay, I'll be happy to jump in from the national level. I think, part of what we do is, one, we do have our association. That in and of itself is important. And the fact that we associate with our most important partner the VA, and that you know, at the end of the day, we have to work in conjunction with the VA, and we have to understand their services. You know, what are their strengths, what are their weaknesses, and the VAs flow down into the states through the. I won't get into a lot of technicalities, but basically the VA hospitals. And so they all have a play within the states and territories and the district. Um, but so we try to bring that together by one, having the organization called NASDBA, two, that we bring the organization together as a whole on at least 2 occasions per year. And so we have a midwinter conference, and then we have an annual conference. And at those, we spend a lot of time talking about, hey, here's what's working, here's what's not working. You know, we've identified a gap, who has a potential solution. And it's some really dedicated people who are involved in the veteran business trying to make a difference. And if there's ever a frustration, it's that the members will say, you know, I'm not sure we dug in well enough on that issue, and I'm not sure we understand exactly what's going on, but we just really feel it's important that we do that. Then within the body of NASDBA, we have an executive committee that meets at least monthly to talk about the key issues that are going on within NASDBA. And then we also have regional vice presidents. And those regional vice presidents have 11 to 13 member states, territories, the district under them to further disseminate information. And what I really want to see even more of is bubbling up. What are those key issues that we're finding commonplace amongst the members, so that we can try to get a collective answer as best possible? You know, and I'll go back to what Andrew said. What's going to work in New York City is not what's going to work in the Wind River Reservation. You know, but if we can come up with the basic construct, then we can further define it to fit the individual needs.
And I'll piggyback off of Tim on that. You know, NACVSO and NASDBA partner together quite a bit, and actually our leadership are members of NASDBA, and their leaders are members of NACVSO, and so we attend each other's conferences. And just like NASDBA, we have two as well. We have a leadership conference in the spring where we bring the leaders and delegates of each state association to DC, where we provide some high level top information on what is going on in the federal level VA. And then we have an annual conference as well in the summer rather, where we bring together as many members as we possibly can. It's typically not a very large conference, but it's about 1,000 members that attend either virtually or in person, where we bring in not only additional high-level VA leaders, but we bring in subject matter experts to be able to provide training to those advocates that are there. We also, just like Tim had mentioned, partner with their leadership team and their legislative team. And one of the things that we've done to try and broaden the scope on helping individual counties and even the smaller states or territories, and then also the tribes specifically, is that we, over the last 3 Congresses, have pushed for what's called the CVSO Act. It's the Commitment to Veteran Services and Outreach Act, which was part of the Elizabeth Dole Act that passed out of the last Congress right there at the end. And that would provide for the first time grants to local, state, municipal, and tribal veteran service offices to be able to help with outreach, to be able to help with suicide prevention, to provide additional full-time employment of veteran service officers or tribal service officers to be able to be in the community to help those veterans in that community where they are.
I'll pile on third here and thank NASWA for their no, seriously, the forums to connect us with our sister state departments of Veteran Services and Affairs, both at that full membership level and all the vendors that come in to expose us to best practices, as well as the working groups and the regional gatherings, are a game changer for making sure we're tracking what each other is doing. We were just responding to a question from another state that NASWA connected us because of specific funding for a specific treatment modality coming out of the state level. So those connections are critical so that we can all be more efficient and work harder together on behalf of our veterans and families. And then I want to tie it into the local level a little bit. So there are a couple of key working groups outside of NASWA that I want to highlight. So at the federal level, Veterans Affairs and then Substance Abuse and Mental Health Services Administration jointly coordinates the public health approach to suicide prevention. And it's named under the Governor's Challenge to Prevent Suicide. And at the local level, there's still some states, there's still some territories that have mayor's level or regional challenges. But Virginia is fortunate to be in our 7th year of the Governor's Challenge to Prevent Suicide. And that provides really good resource assistance and technical assistance for teams across the nation. What are we doing in key priorities like safe firearm storage and lethal means safety education and training to the data that was presented earlier? As well as one of the newer action items to come out of Governor's Challenge teams is with suicide mortality review. So what are other states doing to get to the most accurate data on suicides? And once you have accurate data, how do you then tie that data into prevention? So what did we know about those that we've lost to suicide, and how do we prevent future deaths? So that's suicide mortality review work, which has been really helpful. And then I just left a very energizing All Rise conference, which pulls together criminal justice stakeholders and veteran treatment courts. And for us in Virginia, it's a veteran treatment docket system. And what we learn in those best practice nationwide gatherings, we then bring home to our reentry councils and local level working groups. So those are just a couple of the ways that we share best practices, particularly around specialized services like homeless services, justice involved, and behavioral health.
That's great. And just want to pick up on something you just said about working with within criminal justice. A lot of the things that in the data that Rajiv presented are policies that may not be specific to veterans. So things around SNAP eligibility or issues around affordable housing affect all people in the state or local area, but may have a specific interaction or a different effect for veterans. And so I'm curious how at the state or local level, you interact with other parts of the state government and how that works in terms of thinking about the impact of various state policies on veterans when you're not in the you're not in the role of making that policy itself, but trying to coordinate across departments. If any of you can speak to that.
I'll start and then maybe we'll go in reverse order this time, right? So it just like Tim and others have said, we can't do our jobs without big VA because we're little VA in Virginia. We can't do our job without big VA. We also can't do our job without our sister state agencies. So for an example is healthcare and suicide prevention, for instance. Most of the state funding for those broader healthcare access, like federally qualified health centers, food assistance, and suicide prevention funding more broadly, like through the SAMHSA block grant, it doesn't funnel into your state Department of Veteran Services or Affairs. And so to maximize access to those sub-programs, it starts usually with a conversation of do our sister state agencies and their subsequent programs at the community level know how many military connected individuals they're already engaging with? How many are on their Medicaid rosters? How many are in the SNAP roster? And the answer is not usually a very clear yes, right? I'm sure my colleagues have experienced this. There's varying data quality across state agencies on military connected individuals, and that data coordination and identification has to be a constant effort, which means we're always talking to each other and trying to find data sharing solutions, because it starts with knowing who you're already engaging with, and then learning a little bit more about why you should know more about military connected citizens and what's available to them, like a military culture and resource training, which we try to partner on. And then solidifying those cross referrals and really keeping that relationship both with data and cross referrals going.
Yeah, so I'll go next since we're going in reverse order this time. So it's the exact same at the county level. So as was just mentioned by Brandy, you know, all of the funding for all of the different programs out there are not funneled to the County Veterans Service Office. So we have to partner with our health department or our, you know, local employment security office or any of those other things. But we also at the county or municipal level have to also partner with those separate state agencies. And just like Brandy said, there's a lot of times where those state agencies or those other county level departments are not tracking veteran data. And when you go to them with veteran data that you have, you know, either in your office internally or you're relying on the federal VA with that partnership again, you know, sometimes they're shocked to know the level of veterans that are in the communities that they're servicing. And when they look at their data, when they actually pull that data and they go back and look at it, and they realize that, especially with the partnership with the counties and the federal VA, the federal VA can take a lot of veterans off of that county health department roles and get them into federal VA care, which frees up other resources for other members of the local government. So having those partnerships at both the county or township or town or city level, and then at the state level to work together in Congress to be able to address the veteran issue frees up a lot of other resources at the state and local levels.
Yeah, so I get to go last. I don't know that was a good thing. I probably should have gone first because I might make this answer really hard for you, Carrie, or maybe it makes it really easy. But what they said, you know, they nailed that really well. The one thing that I'll try to add to is this idea of relationships. And you know, so many of our and again, both Brandy and Andrew hit on it, but so many of our issues are multifaceted, you know, and go across several agencies. And what I found a long time ago was the time to build a relationship is not when you need the relationship. You know, the time to build it is now, and then work it in the future. But you know, there are very few things that I can think of that aren't better because I involved other agencies in that process, and allowed them the opportunity, and in some cases or many cases where they allowed me to be a part of that solution.
Great. Yeah, and I think sort of, and then similarly, how you work with the federal government. I mean, I think all of you have referred to needing to work with VA and other parts of the federal government, but there are likely areas of friction as well in that relationship. And I'm wondering if you can talk a little bit about sort of how you balance, you know, the needs of the federal government and the needs of the state and local level as well, and you know, where there are maybe opportunities for reducing friction. I don't know if any of you want to go there.
It's Andrew's turn.
It's my turn to go first. All right. Yeah, so
Well
you
played,
know,
Tim.
yeah, well played, Tim. You know, so changing in administrations, we see this either every 4 years or every 8 years on the federal level. We see it, the same time period at the state level. It's a little bit different on the local level with local elections, but each administration has a different idea of how things are done. And I was actually right before this on a meeting with the Senate Veterans Affairs Committee staffers talking about their goals for the next couple of months. And one of the things that was put out by one of the members was that, or one of the staffers rather, was that if there are things that are happening with VA, don't wait for VA to answer you on those problems. Bring it to us or bring it to your other partner organizations to have a unified front on, so that we can address the problem before it mushrooms. Because there may be some things that are great ideas, there may be things that are not going to work, and you guys are the ones on the ground that are doing this stuff. You need to make sure your voices are loud. And I think that as far as NASDVA and NACVSO are concerned, I think we have a really good relationship with them. We partner quite a bit in drafting letters and providing testimony in front of Congress that goes directly to that point to say, hey, this is an issue that we're finding with VA going down this path. We need Congress's help to address this. Or we're meeting with the secretary or the undersecretaries and having that pointed conversation saying, we understand the reason for this, but I think it's a little short-sighted to do this or to not do this. And one of the best examples that I can give of that is the PACT Act that was passed in 2022. That took several Congresses to be able to get that across the finish line. And one of the big issues with the PACT Act was the funding of it and the amount of money. But the other side of it is the human side, the moral side of saying, hey, look, we sent men and women downrange to fight in several different wars, and they were exposed to these toxins, and they are going to have to deal with this for the rest of their lives. We can either kick the can down the road continuously and wait until it's really bad, or we can get these young men and women these services today so that we can help them and prevent these nasty diseases that may come their way based off of these toxic exposures. And I think that goes to a very important point to show how that interaction between state, local, and federal government working together, even when the federal government might not have the appetite at the time, eventually results in a wonderful piece. I mean, the PACT Act is the largest piece of toxic exposure legislation that's ever been passed in US history. And it was the work of my organization, Tim's organization, and a lot of other people to put that over the line and get those benefits delivered to those veterans.
Yeah, I'll again add to it because he nailed it. Just to put it plainly, when policy doesn't match reality, we have friction points. And that's what the PACT Act was all about, was, hey, the reality is we sent men and women downrange. We put them in conditions that have left them with lifelong conditions that they have to live with. And we owe it to them to do something, or do we? Without the PACT Act, we don't have to do anything. With the PACT Act, we do. So that's a big deal. And so you still see that there still are issues out there. I just the nuclear age warrior, and so there's a period of time where they're covered, but then there are others who have been involved with nuclear testing who aren't covered. And that's a friction point, because to me, I say, well, that should cover every veteran. Well, it doesn't cover every veteran, so therefore we have that friction point. But I'll go in another direction now. Friction points of just knowing, who am I supposed to talk to about this? Where do I even go with this issue? I don't even know where to start. And where I start, are you going to help me or are you going to hurt me? Or are you just going to pass me along to somebody? That's a big deal. And unfortunately, in big government, it happens. And you wish it wasn't part of it, but the reality again is it is. And so it can be hard to figure out what is the right answer and how do we get the right answer applied. So simple things. It drives me crazy when people don't have phone numbers for you to contact them, because a lot of what I do, I want to do right now. I don't want to send an email and wait 48 hours for a response. I want a response by my picking up the phone and calling and getting a hold of somebody. The other one is, again, communication issues. You send information, you don't get anything back. Those are some big and small friction points in my mind.
I'll tie it up. I know we're getting short on time, Carrie, but I want to introduce, it ties in Andrew and Tim's points, I think. So, and it's a little bit more comfortable F word. Don't worry. It is spicy on the East Coast right now, getting toward the end of the day, but not that F word. Force extender. So I think that Andrew and Tim are saying it well, that at the state and local level, we have to be treated and embraced as true force extenders. We are partners in the pipeline for new veterans that need access to, and their families that need access to healthcare benefits, and all of the things that open up in the federal system. But as there are changes in eligibility, both to be celebrated, like expanded eligibility, and then the not so great news, like narrowed eligibility, we have to be good communication partners, because we are the ones educating how to navigate those services. So we have to be true partners in communication and messaging when these changes are occurring. And then we have to be true data partners, right? We have to know how many service members we're getting into our state and how many are going to stay here as they're transitioning from the military. We have to have good numbers on our veterans and their needs. So good comms and data partnerships as we're force extenders, versus frictioners, whatever that is.
Great, I appreciate that. All right, and we have one question from the audience, which is on a specific topic, and I'm curious if this is something that you see in your states and from your vantage point, barriers to oral health care for veterans. And I think this is a good example of where there are likely different policies and different resources in different places. And curious if this is a need that you hear from the veterans that you serve where you are.
Yeah, so right now, as far as dental care is concerned at the VA, the only way to get dental coverage at the federal VA is either having a injury to your mouth and teeth while you're on active service, or if you are 100% service connected. So really the only two. We have been pushing for several years to open up dental care, but just as Tim said, reality and policy intersect. And the reality is dental care is definitely needed in the veterans community, especially those veterans who are less than 100% or don't have a tooth injury during service. But the monetary, the fiscal aspect of it is quite large. So on the local level, what we try to do is we try to partner with non-for-profits that provide dental care to veterans. And there are some great dentists who do things pro bono on the local level. There's non-for-profits at the county, state, and national level that provide dental care, where they will set up a dental clinic at a local VFW post, where they will bring in dentists who will do things pro bono, and the nonprofit pays for the material that's used to help fix dental teeth. But it is something that we are tracking, and it's something that we think needs to be expanded, because one of our statements on our priority list this year for NACVSO is dental care is healthcare. And if you don't have dental care, you are not going to have proper healthcare, and the comorbidities that can come from having poor dental hygiene are quite massive.
Great. That's a, uh, I think that how you describe that in terms of like the different layers of those who are trying to address this issue when it's not being solved at the federal government level is really important. I think is sort of a theme across this that, and as Brandy, as you said, as a force extender, you know, especially in places where there's not yet anyway a federal solution. Great. Well, I know we only have a few minutes, so I want to give you all a chance to have a last word about, you know, sort of this general topic of thinking more locally about the needs and services of veterans and how those solutions may come both from the policies and resources at the state and local level. So you can each have a minute. Let's see, Brandy, you can start, and then we'll go around.
All right. Well, thank you guys for tuning in, and to Rand for hosting. Everything, as the panel has said, is built on partnerships. So whether it's partnering with our federal agencies, our sister state agencies, and where the real action meets the road is, of course, at that local level. So it's finding the forums that you're trying to solve, right? So if you're with Justice Involved, you're in the reentry councils, homeless and housing services, your homeless service planning bodies like continuums of care and suicide prevention coalitions. Find the people that you need to your left and right to really impact change. And usually, of course, if we don't have funding to bring people to the table, because it may take time to get that, see if just good dialogue about military culture, what's available to this community, and data can get you started. And when you have those things, then you can jointly go after the funding, and then, you know, the sky's the limit. Thanks again.
Well, I'll go next. I guess thanks Rand for hosting this, and thanks everyone for joining in to listen, and thanks for the questions. And what I would say too is that I'll take this from the national side of my organization is, you know, funding is not uniform throughout the country when it comes to funding the local, whether it's the municipal or the county level veteran service offices. And that's a huge problem because there is disparity in care at that local level. And there is an issue that we have, and this is probably going to shock some people after we were in 20 years of war, but there is issues at the local level and some local political leadership who do not have a taste or a desire to care for their veterans, even though they're mandated to at the state level. So one of our big pushes is working towards uniformity across the states as far as what it looks like at the local, the county, municipal level for funding for veterans.
Great. And Tim?
Yeah, well, you know, we've talked about it, but I mean, I think a simple expression is you break them, you buy them. And that, you know, that's the way we should look at it, is if we break them, we buy them. And, you know, we need to be, I talk to the military entrance stations, or the who's providing potential soldiers, airmen, sailors, Marines, and guardians, and ask, you know, are you really sure you want to try to push that person through? Because there's a bill that you may have to pay on the other end if they really weren't in the greatest shape. So I just do that on the front end. On the back end, I go back to, you know, it really is. And they're all, and the other thing I'll go back to is that they are all snowflakes, and we need to treat them that way. We can't have two, you know, what works for me doesn't necessarily work for Andrew or work for Brandy. We need to make sure that we're very specific. And that's why it's so important that it's at the local level, because that's where we really make the difference. The last thing I want to talk about that didn't come up that I think is an important issue is caregivers. Caregivers is becoming more and more of a big business when we talk about veterans, their families. and survivors, is how we take care of those folks in the long term and who takes care of the caregiver.
Great. Thank you. And thank you, all of you. This has been a really terrific webinar and discussion with all of you. We really appreciate it. Thank you so much.
Thank you.
All right, thanks, everyone.